blows my mind that we're so scared of gluing buttons to teeth. It's literally the easiest thing. Like you guys do fillings. I don't even do fillings. I do no general dentistry. You do things that are so much harder than me every single day. So this patient is 16 years old, and in reality then, he should be treated as a non-growing patient because he's not. He's past puberty. If we look at his C-spine, again, this is covered in other courses, but if we look at his C-spine, we can see that looking at his cervical vertebrae 2, 3, 4, we can see that he has a notch in them and that it's no longer a smaller rectangular shape. It's now increased in size to become more of a vertical rectangular shape. And so that is the indication here that this patient is not growing. When we look at his facial balance, it's okay. I mean, he has a more prominent nose, so his labial angle is significant. But relatively speaking, are we going to be making significant changes to his face? No, we're not. Right? Essentially here we're treating the teeth that are in the patient's face, and that's the situation. So this is the difference then between this patient and the last, is that we're not expecting that we're going to see significant changes with the patient's class 2 situation from growth. We might see it if we're doing things like sequential distalization. That's a situation where we can accomplish those movements, but we're not going to be seeing it from growth with a bite jump. Remember that simulation that we had on the last plan that showed how the bite was jumping together. Okay, so let's go ahead and take a look at the clean check. All right, so the situation that we have for this patient is we have their upper lateral incisor is blocked out. They're also biting in a crossbite. Let's actually get rid of all the attachments right now so there's no distractions. Okay, his lower canine, the lower right canine, is a primary canine because on his pan, you'll see here that we mentioned this before, he has a lower canine that's completely horizontally impacted. Now, when a lower canine is crossing the midline to this extent, the challenge is that if we're trying to bring that tooth upright, on the palate, no problem. We absolutely can do that. We do it all the time. But on a lower canine, the challenge is because this tooth is positioned buccally, as we upright that tooth, well, it can strip the gingiva. It also can add and lead to a lot of gingival problems. And so a lower horizontally impacted canine like this, that's so far impacted that it's actually inferior to the roots of those lower incisors, in many circumstances, the best treatment plan for this would actually be to take it out. Now, one thing that I have seen, which is kind of cool, is that I have seen orthos before that will actually work with a surgeon and they will make an incision down here. And what they will do is they will actually bone graft the crap out of this and try to bulk up that bone so they can then upright that canine through the bone without causing periodontal and gingival issues and then bring that tooth into place. So it's not that this is impossible, it's just it is very heroic to try to bring this tooth in place, and a better situation would likely be leaving space for a future implant. So what is the plan? Well, when it comes to his crossbite, I hope you guys know the plan. There's a blocked out tooth. For the anterior, what are we going to do? Well, we need to make sure that there's space around that tooth. Again, this is the number one reason that your cases will not work with bringing a tooth out of crossbite. It's that you don't have room around that tooth as it's moving. So make sure you have space around that tooth as it moves so that it does not collide with the neighboring tooth. And this is the way I like doing it nowadays, is that I literally leave 0.3 millimeters of space, mesial and distal. Because here's the thing, guys, how hard is it going to be for us to close that 0.3 millimeters of space later? Like the easiest thing in the world. It is so straightforward to close space between teeth at the end of treatment. Like you don't even need attachments on the teeth. This is one of the few things that Smile Direct Club could even accomplish, was closing space between teeth. So closing this space is not challenging at all. So this is the plan. This is how we design the first clean check, is just leave space. We'll tighten it up later. No big deal. So what are we going to be doing on his left side? Well, on his left side, because we're biting in a crossbite, what we're actually going to look to do is, first of all, from the tooth movement standpoint, what did I do that wasn't the best in the last plan? Well, in the last plan, remember we had the palatal cusps where we first started off, they were hanging. Well, these palatal cusps are hanging a bit too. Well, at the end of this plan, I actually have put more buccal root torque into these teeth. So as we're moving them and expanding them, we're actually also adding in buccal root torque. The other thing that we have that we did not have on the last plan is we actually have horizontal attachments. Whether they're horizontal attachments that are conventional or whether they're an optimized retention attachment, essentially what we need is a flat surface on the gingival aspect of these teeth in order to ensure that we can create proper expansion. So you can see, ignore the distalization right now, but we have some arch development. And on the lower, what you'll often see with these crossbites is that the teeth might be further out than they should be. So we actually want to add in some constriction to the situation. So we're going to have some constriction of the lower, some expansion of the upper. And when we finish this, we're actually starting off, or where we finish, we're slightly over-treated. So we're not finishing it in the perfect ideal spot like this. We're actually overdoing it slightly, right? We're over-planning it. Now, how would we actually go ahead and do that ourselves? Well, let's go back to our demo case. If you want to go ahead and change the position of these teeth, there's two ways to do it. One would be to grab the teeth with the 3D controls, and you could actually go ahead and move all of these teeth slightly towards the lingual. Or the other thing you can do is you can click this arch feature. And the arch feature allows you to, it's done that you need to click lower, then it puts the top arch back again, then you click lower again. But what you can actually do then is you can grab these little black dots. It's a little bit hard to see since I go black on black with the colors here, but you can grab these little circles, these dots, and you can constrict the arch that way. And if you only want to do it on one side, just click symmetrical movements off. So now we go ahead and you can expand, you can constrict, it'll just all happen together. Super easy. Right? You can even do more. This is me just stopping it. Like, obviously, this is too much. But you have control over this. And so all we're doing then on this plan, this particular plan, is we are overdoing the expansion slightly and underdoing and overdoing the constriction. So that at the end of the day, he's actually hitting more on the palatal cusp. Now you might say, well, Stephen, we just talked about we don't want to hit the palatal cusp. Well, in this situation, I realize that the movements we plan are not going to fully express as shown because they never do. Whenever you're moving roots through bone, they don't move as much as what you plan. So that's why I'm overdoing it. We're starting off in a crossbite. We're almost finishing in a scissor bite. Okay, so what next? Well, in his situation here, we're going to use crossbite elastics. Again, you guys will realize as you get more comfortable with this is that elastics are not scary. Buttons are not scary. Like it blows my mind that we're so scared of gluing buttons to teeth. It's literally the easiest thing. Like you guys do fillings. I don't even do fillings. I do no general dentistry. You do things that are so much harder than me every single day. But for me, like gluing a button, literally you take a button, you put a bit of cement on it from your cement dispenser, you etch the tooth, you bond the tooth, you plop it on the tooth, and you cure it with a light. That's it. To take it off, you use a little debonding plier, you literally grab it, you squeeze, it pops right off. I probably took off 30 to 40 buttons today. And we have elastics in most of our patients. Now, I'm not saying you have to be doing this. Don't get me wrong. I just want you to understand that this is something you don't need to be scared about. We can help you get over that anxiety. And it's funny because a number of doctors have come to me years later and say, Stephen, I was so terrified of buttons and elastics and like, what was I scared of? Like, this is not hard. And they're such a good tool to help you with more complicated things. They help get you out of trouble. So we utilize the elastic. So what we're doing here is we're going with a button from that lower first molar to the lingual side of the upper first premolar and the lingual side of the upper first molar. Pretty easy. So what does this look like in terms of how the elastics would actually go? Well, I'll sketch it. Right, upper first premolar to upper molar. Now you could do this differently. You could have gone from the lower, here, let me just draw it. You could have gone from the lower first molar, let me make that bigger, to like the upper second molar, and then to the first molar. Like you could have gone like this. You could go like this. We could have gone like this. I don't care. It doesn't matter. The main thing here is just that you're using an elastic that's going from the buccal of one tooth to the lingual of the other teeth. That's the key thing. right? And so the patient just hooks it on. Super easy to do. Again, check out the You Don't Know What You Don't Know course for more information about elastics. I think I cover it for like 45 minutes and show a lot more examples of elastic usage. But all you really need to do is you just hook the elastics on. It goes to the lingual side here because we have a button right there. There's a button right here and hooks on to a button right here. And the size that you'd use would probably be a 1/4 4 ounce. Again, if you don't know what that means, go to attachments or go to You Don't Know What You Don't Know, and you'll then know. The attachment that we place on the lateral incisor you can see here is actually on the lingual side. We could place it on the buccal, doesn't matter, but we place it on the lingual side in this case. Now we have some other attachments, and if you've seen me teach in the Invisalign Demystified, you've seen more information before on how to rotate teeth with the sash attachment, and all that kind of stuff is pretty basic, so I'm not going to go into all the attachment designs for everything here. But the main thing is here is that there's not a whole lot going on the patient's right. On the left, we've got the crossbite elastics. I do want to point one thing out, though. For the crossbite correction, I just told you it does not matter if you hook your button from the buccal of the lower to the lingual of really any of these upward that are pretty much in crossbite. But there is something about this that is more in depth. This patient is class 2, right? He's biting in a class 2 bite. Now, is this a growing patient? No, it's not. This patient is not growing, so we cannot expect that we're going to see the bottom jaw jump forward into a class 1 because that's only happening because we're modifying their growth with the elastics. So instead, if we want to accomplish class 2 correction, we need to do something like sequential distalization, where we are actually backing the teeth up 1 tooth at a time. That is a way that we can move the teeth back to help correct the overjet and the class 2 situation. And so to do that, any time that you are backing teeth up 1 tooth at a time, you must utilize elastics. It's a must. Your ClinCheck could show you exactly what you see here, showing 1 tooth backing up after the other without having a class 2 elastic orientation, right? And the traditional class 2 orientation would be going from the canine to that first molar, like you saw in that last case. That's your standard class 2. But wait a minute, Stephen, we have a crossbite. We need to use these. I need this lower first molar right now for my crossbite correction, right? Because you've said we have multiple teeth in crossbite. It's not just 1 tooth. If this was just 1 tooth, you could probably go ahead and just correct this without any elastics at all. Who cares? 1 tooth in crossbite, not that big of a deal, as long as it's not your last tooth. If it's your terminal tooth, then you still need elastics. But if it's like 1 tooth in the middle of the arch, who cares? But in this case, no. We have multiple teeth in crossbite. So what are we going to do? Well, we have to use the crossbite elastic. That's really important in this situation because we're trying to fix it. But we also want to have the class 2 component. Well, that's why we put the button cutout also on the inside of that, on the lingual of that upper premolar. Because not only do we get the crossbite component, we also then are accomplishing, we get the crossbite component going here, and then we get the class 2 component going anteriorly. So that is what is giving us both corrections. We're accomplishing both. So anytime if you ever want to do sequential distalization to back teeth up to correct a class 1, then that's the move. Now, if I was doing this again, what would I do differently? I would actually plan a little bit more sequential distalization in. I didn't want to overtax the system. I didn't want to overdo the distalization, so I kind of like let up. I took my foot off the pedal a little bit. I would have done a bit more. I wouldn't have gone crazy with it, but I would have done a bit more because I think we could have accomplished a bit more. So here's the ClinCheck, right? We correct our tooth that's in crossbite. We work on our deep bite correction. Right? Deep bite correction requires you to have attachments on your premolars and molars, specifically horizontals, just help intrude those teeth and flatten your curvus B. Again, a fairly more straightforward concept. If you've heard me speak in other demystifieds, you would have heard that. On our premolar, we're focusing on our rotation, right? So we've got a vertical attachment here. to help derotate that tooth as it's also constricting. Okay, and so what did we accomplish? Well, here's where he first starts off. This is where we're at after treatment plan number 1, after his first round of aligners. So we jump the crossbite, but the lateral, consistent movements. There is maybe a little bit of space around that tooth. Maybe not even that much. But you know what? I'd rather have more space than less. In terms of our arch development, wow, that looks great. If we start hitting against the cortical plate with our expansion, it won't go any further. And then we'll have to address it later by extruding those teeth or undoing a little bit of the expansion. But look at that expansion. Like, that's beautiful. So I'm always frustrated when I always hear people saying that you can't arch develop in all adults. Don't move molars, don't do anything hard. Well, no, that's nonsense. Are we hitting in a bit of a posterior open bite? Yeah, we are. Do I care? No, because we're on the fairway right now. We're not putting yet. We still have more batches of trays to go. So who cares if it's a bit of a posterior open bite? We have a lot of time to go ahead and solve this. We jumped our crossbite. Like, that's awesome. Our crossbite is corrected here. Sweet. Right, our lower, minor crowding, but you can see that the constriction that we planned in. Now, the trays do a certain portion of that, but the elastics are actually what makes the magic happen. And our lower premolar that we needed to spin, well, look at how that tooth spun. Beautiful. Great rotation of that tooth from where we first started. So all in all, if you started off with this plan right now, do you think that you could finish this case? Probably. You probably would not be too scared about doing this plan. Whereas if you saw this initial plan, you'd be saying, whoa, 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 this is a lot. Stephen, what is going on here? I don't know that I'm comfortable trying to correct a crossbite and sequentially distalizing these teeth. That seems like a lot. That's heavy. But at this point, well, man, the patient's pretty much in class 1 with a bit of posterior open bite. You know, you have this in your back pocket now. You've seen how to use it. And once you watch it, you don't know what you don't know. You'll know how to use elastics every day of the week. Super easy stuff to do. Pop some elastics on here, run some vertical elastics. You could close this open bite in like 2 weeks, a month, something like that. Easy stuff. We're in nice class 1 occlusion over here because we always were. It's not that I did anything special. Our midlines, bam, spot on. I mean, his midlines were pretty close to being on before, so how much credit can I take for that? But I still will. No, I'm kidding. So where are we at now, right? So what are we going to do at this point? So we're here. So what do we need to work on? Well, we need to work on now settling our posterior open bite. We need to work on getting the occlusion into better spots. Like, I know I said we are still on the fairway, but in all reality, we're kind of on the green, right? We're not in bad spots. So I'm not changing my attachments. So I don't need to waste time on appointments. I'm just essentially pushing down on the gingival aspect of these teeth now to extrude them down into a more solid bite. And I'm intruding my palatal cusps. So I'm actually even intruding these palatal cusps. Like, check this out. This palatal cusp is hitting heavy. So what am I doing? I have good attachments on these teeth. I have horizontal attachments, which I did not have in my last case. So we're intruding the tooth and we're putting in lots of that buccal root torque to the point that I literally don't have contact between the palatal cusp of my second molar here and even my first molar. It's hard to see. I don't know how far in I can go, but I literally don't have contacts. If we click on our occlusion here, it's kind of hard to see, but I do not have any contacts on any of my palatal cusps. Right? Because I know I said I was kind of on the fairway, but no, I actually, like, this is what I'd call a par 4. I actually landed on the green. I'm putting for eagle right now, but it's a long putt. So what I'm doing is I'm overdoing that. We start off with heavy contacts on our palatals. I overdo the intrusion, so I finish with no contact on my palatal cusps. Again, if right now you're listening to this or you're watching this and saying like, holy crap, Steven, this seems heavy. I don't know about all this stuff. Like, I'm just doing my first few cases. I don't want you to get discouraged because I'm hitting a lot of concepts right now. And here's the thing is, I don't treat you like a kid. I'm going to give you hard things that you can learn because here's the thing is, if I just give you cookie cutter recipes and say, don't do these tricky things, then you're not going to learn and you're not going to use your brain to get through these challenging situations. So I would much rather give you the insights, even if it's hard, even if it's difficult, Watch the next demystified or the following and the next one. And as you do more cases, you will get more comfortable with these concepts. So please just understand that that's always going to be me. So I will always push you and try to make your head hurt a little bit and show you what is possible because that's what's missing right now from orthodontic education for GPs, in my opinion, is really pushing the boundaries of showing not just a template or a cookie cutter recipe, but really helping you think through the problems. Because once you understand how to think through them, then nothing becomes hard, nothing becomes stressful because you're not memorizing, you're just doing, you're practicing the principles and the concepts instead of memorizing. Rant over. Okay, so we intrude these cusps. We buckle root torque on them. Again, here's how you would do it on your actual plan if you wanted to do it yourself. You'd go to the tooth, you'd go to your 3D controls. I've kind of messed this side up, let's go to this side. You'd go ahead and you'd be like, wow, I'm hitting heavy on this palatal cusp. What am I going to do? I'm going to go ahead, I need to make sure I have horizontal attachments. Now, again, in attachments and biomechanics, I teach all the rationale, the theory behind how this works, why you need these attachments. But right now, I'm just going to tell you that you need them. You're going to grab these teeth using the tooth movement. If you are not utilizing 3D controls right now, you should, because it will make your life so much easier if you are utilizing 3D controls because you take control of your own plan and you are not dependent on the Invisalign technicians to try to understand your garbled instructions. Sorry, guys. They're honestly very garbled. It's normal. It's normal that we don't communicate great with the technicians, but this is all we had to do. Literally what I just did, boom, done, finished. That now is buckle root torque. If you're hitting the cortical plate, this will not express. It will just stop happening. It will not express, and we will have to use a different strategy like vertical elastics to pull down those cusps or put in a little bit of constriction. I'm not going to show that right now, but you have options that you can use to get out of the weeds if you're hitting heavy on your palatal cusps. So that's how I planned this on that case. Those are literally the movements of what I would have done. So that's what I'm doing on this side too. I'm intruding any spots where the palatal cusps are hitting at the beginning of treatment. I want them to not be hitting at all because that's the mistake I made in that last case and why I had to do so much more work. Because the reality is this, I only use the vertical elastics to settle my bite maybe on 3 cases out of 400 per year. That's it. It's not something you usually have to do. But again, this is why it's actually so beautiful having so many cases. Like literally, I finished these cases today, and I can show you 2 different scenarios of the same problem. It's the same things that are going to come up again and again and again. And if you know how to solve them, then it doesn't cause you stress. It doesn't cause you problems because it's not that big of a deal. So let's go ahead and take a look then after this plan, what actually was accomplished. So here's where we were after the first round of trays. We didn't use vertical elastics. We intruded the palatal cusps. And here's where we're at. Right, those buccal cusps have come down and the palatal cusp has been intruded. And we're in this nice class 1 occlusion. On the other side, we're still nice class 1 occlusion. Our midlines may be slightly off here. We were doing a bit of movement on this lateral, and we do have the lateral slightly out of position. But yeah, this is really great. Like we're in a good spot. Again, if you had this case right now, would you feel comfortable finishing it off? I would hope so, because there's really not that much that's left to go on this plan. So here's where we're at. So maybe we're going to do a little bit more settling because we're still a bit off. Right now, we are literally like this is the equivalent right now of putting from like 5 feet out. Like we are so close to being settled with our bite. So any heavy palatal cusps, because we're still a bit heavy on some, what do? We intrude them out of contact. A little bit of constriction on our lower arch to try and help settle the occlusion. That's it. Super straightforward, super easy. It's not a really challenging thing to do. And so what do we get? Well, we're right here. Now, again, here's the real world. These are my patients sometimes. Look at how horrible his hygiene is. Isn't that garbage? Ugh. And we give them crap. I mean, the thing that you end up doing the most when you treat teenage patients is you literally talk to them about how they need to brush their teeth better. That's what my life consists of. I pretty much lean on walls, I make bad jokes, I talk to parents, and I talk to them about these kids, about how they need to brush better. And I try to scare the crap out of them. So we're nice 1 canine. Maybe not as intercuspated as I might like in this area here on our premolars and molars, but it's pretty good. Now, some little tweaks that I made just with the last plan. Got the midlines slightly better. Now, this wasn't anything crazy that I did. I'll go back to the plan. Like, all we're really doing here is just the midline slightly off as there's a bit of intrusion. To be honest here, guys, I don't even really worry about the midlines until we get really, really close to the end. At the very, very end, that's where I might look at the midlines for a midline elastic or something else. But so at this point now, what we're pretty much ready for is we essentially can just go ahead and focus on now our active retainers, right? Just to settle any remaining bite issues, if anything's a little bit apart, and to tighten up any contacts. So in every single one of my patients, I'm always using these active retainers because all I'm doing then is anywhere that has a loose contact. So when we floss, if there's a loose contact, I put in fake IPR. It's just IPR that I don't physically do. Although ironically, we did have some spots where it's detected that there was loose contacts, but I don't think there actually were. But we put in some fake IPR here. We don't do this IPR. All it's doing is it's forcing the teeth tighter together. So if this was a bit loose, there's a little bit of a gap. We just literally put in IPR, but don't do it, and it forces these contacts together. Because I don't use virtual C-chain. Instead, I use fake IPR to tighten my contacts instead. So it physically moves the teeth slightly inside one another, only at the areas where we actually have loose contacts. Now it's showing some black triangles here. Like he doesn't have black triangles here, but for some reason the ClinCheck's picking up more, or thinks he does at least. But that's essentially what we're doing, is just settling the bite a little bit more, stabilizing the occlusion. That's it. Or we're just settling things a little bit more. So where's he at then when he comes back? So again, there's a little bit more settling I want to do. Did we get much more? No, we didn't. But am I happy with where we're at? Yeah, we're biting in a great class 1. Canine on both sides. Our midline's pretty much spot on. We corrected the class 2 that he started with. We corrected his crossbite. Right? This is a non-growing patient that we accomplished these things on. Now, this does not mean, here's a key thing. We're at 7:58. So hopefully you're all still awake. Now, you East Coasters are troopers. I'm always amazed right now. We were at 199, we're at 194. So we've only lost 5 people in 2 hours. So like you guys kick ass. The thing I want you to take away right now from this is we do not always fix class 2s, and we do not always fix crossbites. It's not something we will always do because there are circumstances where we shouldn't fix them. If somebody has a skeletal discrepancy, they're skeletally constricted, you will not be successful correcting their crossbite. If someone has no mandible whatsoever and they walk in like this, you will not be successful correcting their giant overjet because they're non-growing. If they're not growing, you can't fix that. Like you can't. It's just a reality. So that's what I want you to take away from this. It's just that um, there are circumstances where you can, and again, that's where being part of Clearly Select is we will help you with your treatment planning and your case selection so that you don't take on things that are outside of what you should be doing that are biologically impossible. We will help support you with that. We will give you 10 ClinCheck plans that we will design and plan with you. And I will give you, or my faculty will give you breakdowns on your treatment plan so that you can see a successful treatment plan for your own case, breaking it down in detail. Right? Those are the things that we want to supply to you because we know what it's like. I know what it's like to start off and feel like you don't know when you click that accept button if things are going to work or not. And so that's where we're there to support you with treatment planning. We're there to support you with design of your cases, with operations, with logistics, with systems, with the educational component. That's all included for those who may be interested in Clearly Select. Right? Because that's my mission, that's my passion. This is what I want to do for the next 30 years is bring this knowledge that I got from traveling all over the world to bring it to you guys and to make a difference in how we treat as a profession and showing you that you can have an amazing lifestyle where you could work 1 week out of every 6 and make as much money as you were working full-time doing general dentistry and have way more fun doing it. I've given 10 needles this entire year, not even. Right? I don't do anything. My staff do all the work. I literally take off some patches sometimes and do some IPR. That's it. It is amazing what you can do with plastic and elastics when you use your brain, and it's so rewarding to use your brain. So that's what we're here to help you do, is help you to use your brain to understand how to do these things, because understanding matters more than anything else. So again, here's his final position. Really happy with the occlusion, happy with the midlines. Hygiene is terrible. We've been harping on forever. And I told you one more thing that we were going to do. I told you I was going to show you the surgical photos of that tooth being extracted. I won't pull up the CBCT, just we're already at 801. But here's the tooth to start with. It's to the buccal. That's all you need to know. And the other thing just to know about it is that when you look at the CBCT and where the tooth is positioned, you can see it's pretty much like right here. And so you make an incision right there, you flap this back. I used to do stuff like this all the time. I had my IV sedation training. Now, this is one of the associates in our practice that I taught how to do this years and years ago. Um, then they now are doing it. So let's go to our proper photos. Okay, so here's the situation, right? This is why I love our office. We're so good at documenting. I was like, Hannah, I need you to go ahead and take really good photos. So I want to show doctors how to do this. Okay, so here's the flap. Retraction, remove some bone, find the tooth. Chop the crown off. Now the crown is chopped off, which is here. And then use an elevator, prop the elevator between, pop the root out. There's no periodontal ligament, so this tooth is going to pop out really easily. This is what it looks like when it's actually cleaned up. So you can see here's the hole. We're staying away from the mental foramen because it's not close there. We're accessing it through the area here. Like if you actually take your Explorer, you can't really see it from this angle here, but you could actually pop through this bone to where the crown is. Like it's literally kind of right in this area here. It's very soft bone. You pop your Explorer through, you'd hit that tooth. Now, if you were doing a impaction uncovering, you would do pretty much the same thing. You would just literally do this. You'd find that crown, and then you would go ahead and uncover around it. Like this is now showing, oh, actually, I'm wrong. Sorry, guys. This is actually, I think, the crown. I don't know, actually. Is this the crown or is this the root? Unknown. But you would just go ahead and you'd uncover the tooth, and then you just bond a button to it, run a stainless steel ligature through, make a hook. Again, I taught this at Demystified at at Demystified at Clearly Illuminate, which is our annual conference, available to those in Clearly Select. I'm teaching, again, we're going to be having that one in the Bahamas next year. So you can't attend the conference unless you're a part of Clearly Select, but if you want to come, we have 5 days of education. It's only $1,500 for those who are in Clearly Select. We're not trying to make money off of it. We're just trying to cover our costs. But I taught on impacted canines last year in Palm Springs. And so section the tooth, you could bone graft this, pack some bone grafting in. I don't think we did in this case. And then you're going to flush it, suture it back up. And this is what it looks like. And then this is the area where the incision was, kind of in this area right here. And everything looks good. All the bone fills back in, and that tooth is now removed. So there's your bonus surgery education. So that's the takeaway I want you to have from this, right? And I think a lot of the times why speakers don't always show all the problems that they go through is because you're putting yourself out there, right? There's 199 of you right now who are looking at my cases. And I mean, that's what my goal is, not to be your guru and to tell you, here's a formula and you do it the exact same way every single time. My goal is to give you the knowledge and insights to recognize that there's solutions to these problems. That's all okay. It's totally fine if you want to treat it a different way. I'm just trying to show you, again, the different scenarios of where we treated something and how we had to work our way out of some of the problems that are in front of us. The beauty of this, again, is that when you are treating and you're placing an implant or you're pulling a tooth, you can't say to a patient, hey, you know what, we got half your tooth out, we're going to finish the other half later. No, but when you are dealing with orthodontics, you don't need to have everything figured out from the start. And if you have a supportive community where you can work through these problems with doctors who know what they're doing, then it's okay if you don't feel like you know how to putt on this par five, because that's the whole vision and goal of our Clearly Select group, is that we are there to support you through these situations, through the challenging times, to give you the insights and to give you the tools so that you can say, you know what, elastics and buttons, that's easy. It's classic Steven. You guys know, if you've been on Demystifieds before, I get really into the cases. I want to go through all the details because that to me is so important. But man, I could talk about this for 8 hours. And honestly, I do talk about this for 8 hours or longer when we're doing the courses. So if you haven't ever seen me speak live and in person, I would love to see you guys there. And if you, again, want to take your practice to the next level, I would really love to have you find out more about Clearly Select, where we work one-on-one with doctors and as a group with our Clearly Select faculty to help bring you support.